All right, hello everyone. Hope you're having a good week. Guess you'll be watching this after the exam. Hope it wasn't too stressful for you. Um, and I'll email you separately about when you can check your tests. You may have done that before you even see this. So anyway, finally we're getting to an actual chapter with an actual disorder, and that's what we're going to discuss. So this is DSM-5, anxiety and obsessive compulsive disorders, two separate sections. Was different in DSM-4. So all the stuff we've been talking about, you're going to see in practice here, and one of them is they decided to separate them out. So anyway, let's get right to it. So, but they are dividing them, and the chapter's divided into two separate sections. Okay. Again, love these questions. How do different paradigms attempt to explain the development of anxiety disorders? How important are specific traumatic experiences in the development of phobias? It's kind of a specific question. A lot of phobias, we really don't know where people got them from. Some, it's very clear. But in terms of phobia versus PTSD, it's always clear where you got it from. We're not always clear as to how people get phobias. Sometimes you dig in the childhood a little bit, you can see a couple of things. So we're going to talk a little bit about treatments, and then OCD, obsessions, compulsions, the difference. We're going to have to talk about that a little bit in our discussion period. So, and then different kinds of treatments. So they're quite frequent. Prevalence rate, lifetime, meaning if you just ask people if they've ever had it, 28% will say yes. In other words, met criteria for. All right. Point prevalence would be if you asked them right now how many people would say they have a disorder. Different. So, all right. So from 4 to 5, they are related disorders in two separate classifications. Don't ask me why. I'm not sure you could ask them why, but we're going to leave that for now. So a little background here in terms of fear and anxiety, and I'll let you read this. We are born with an innate capacity to experience fear. So if you think about the Pavlov model, it would be certain unconditioned stimuli will elicit unconditioned responses, just like a knee tap will get an automatic knee jerk. Certain types of events will elicit fear, and then fear can become conditioned, right? So you can condition fear to a bell. Fear is like salivation. It's an automatic, involuntary response. All right, so difference between fear and anxiety. Real threat or danger, and anxiety is more apprehensive anticipation of future. Okay? Yeah, we could debate that. Just know the definitions. A little bit. So this is a very important slide. So when I say that, you should be scribbling notes. I hope you're taking notes on the recording. You should be taking notes when you read and taking notes on the recordings. So really, anything in psychology that involves emotions, there are three aspects of emotions that you can measure. Subjective experiences, all right? So that would be self-report, what the person says they are feeling. The other is behavioral manifestations. So their behavior, running away, running out of the airplane because of the anxiety. They did, if you do studies, there was a study of some sort of fearful stimuli presented in a movie, and they had little sensors in the bottom underneath of the chair that could detect how much the seat moved. Right, so that's all behavioral stuff. What could you observe? And then physiological would be body stuff, right? So heart rate, it's everything that a lie detector measures. Okay, heart rate, breathing rate, that's why they put the thing across your chest. That's why they put the electrodes on. It's not electricity in, it's measuring how much very small changes in your sweat glands um, increases or decreases the conductivity of electricity across the little things. You don't feel any pain, but that's why you get those put on you. Dilated pupils, and you can also do similar for muscle tension. You can have one of those little leads for muscle tension. So this is a very important slide in general, and it's important that you know it and understand it. All right, we may not go so much over sympathetic and parasympathetic nervous system. The sympathetic nervous system is kind of like the gas pedal, and the parasympathetic is like the brake pedal for your physiological responses to that are related to emotion and fear. Okay, there is one exception. If we look at a graph, I may talk about that. But so basically, your sympathetic nervous system kicks in when you have a fear response, and then when you're trying to calm it, your parasympathetic kicks in. So the issue with fear responses is if you get, instead of Bell food, if you did Bell and a pain stimulus like a shock or a sudden loud noise, right? Something scary, all right? The scary thing or the pain, right? The painful stimulus would elicit that normal fear reaction. And if you do that enough, the Bell will elicit the fear reaction. So that's all they're really talking about. And what we may talk a little bit about at some point is that it's right, people who have a lot of who have PTSD for sure, there's things they will be afraid of that aren't exactly related the same thing as what they experienced, but it's going to be things that are generalized from it, right? So Vietnam vets didn't like open spaces because they tended to be more dangerous. They didn't like to go into Asian restaurants. And more complexly, they didn't like to be close to people emotionally because fear and loss had been associated with those kinds of things. And observational learning too. So some basic concepts. The book goes into it a little more, and I'll let you read the book and ask questions, but those are the basic concepts there. These are the main disorders: panic disorder, agoraphobia, specific phobia, social anxiety disorder, social phobia, generalized anxiety disorder, separation anxiety disorder, so you see that more with kids, selective mutism, they're calling an anxiety disorder, and then always going to be a category of other. So what you're going to have to learn here now, you're going to learn how DSM-5, not just about anxiety, but how DSM-5 works. It's going to relate to all the stuff we discussed in the first 4 chapters. Okay, so panic attacks can be part of different disorders. All right, agoraphobia, all right, fear of being outside your house. You can have different disorders that have those things. Just that thing, you can have panic disorder, but just having panic attacks, just having a fear of going outside your house may not be a disorder by itself, although it can be. All right, so you see how this works. All right. Panic attacks are terrible. If you've known anybody who's had one, or if you've ever had one, just a terrible, awful sense that something really horrible is going to happen and tremendous need to escape the situation, right? Intense fear, and that a lot of people feel like they're dying. Not so common in kids. I'm curious about the age at which people start to develop. I don't know off the top of my head. Panic attacks. Having a panic attack is not by itself a diagnosable disorder. Okay, so what you've got to learn is there's pieces to the puzzle, and then different pieces fit together for different disorders. Okay, so if you look at this graph about a panic attack, now we're not talking about a diagnosable DSM-5 disorder, we're just talking about a symptom. or a set of symptoms. What do you notice about these symptoms? If you think back to the slide with the 3 ways you can understand emotions and measure them. Right. What is predominant here? All right, so now I'm not sure about the organization of this chapter. So now we're going to talk about, these are the main disorders. It gives you a little bit of the key symptoms here, all right? So make sure you can see as much as I can see. But I believe that's in the book also and in the slides. So gender differences, I'm not going to go into this. I expect you to read that. We'll decide later whether it's going to be in the test. All right, here's our first disorder, panic disorder. So you have to have, of course, recurrent, spontaneous, and unexpected panic attacks. You can't have panic attacks only in McDonald's. You have to have a lot of fear about them coming because they're horrible, and your life starts to revolve around wanting to avoid them. Here we go. Cannot be due to a medical condition or the effects of a substance. All right, so it's got to be, they wouldn't like the word psychological, but cannot be those things. And now you're going to start to hear about categorical criteria and how they work, followed by 1 month or more of persistent concern that the attacks will reoccur or it leads to significant changes in behavior, like staying in your house. This will get confusing a little bit. Okay, so a little background. Onset, when it starts, right? Adolescence, mid-30s. Course is highly variable. It means you can have like a lot of symptoms over months or years and then none. So different for different people and can be different within an individual in terms of what the pattern looks like in terms of the severity. That's what we mean by the course of the disorder, right? Onset, when it starts, typically. Waxing and waning, worse and less. Nocturnal panic attacks. I'm not sure about waking up with a panic attack versus night. I'm not sure what that definition is. More common around women, so we can talk about that. So this is just panic disorder. I think a lot of these slides will actually have the panic disorder symptoms and the criteria that need to be met before you can get that diagnosis written down by your MD or a psychiatrist on your form that goes to the insurance companies. All right, biological causal factor that's known to run in families. Speaking Chinese runs in families. Do you think that speaking Chinese has biological cause versus speaking French, that it would be different? No. So it's evidence for, but it's not conclusive at all. You grow up around a lot of panicky people, guess what? Is that biological or is it environmental? Some evidence that some of your brain areas, you learn about amygdala in Dr. Herzog's class. GABA is a type of neurotransmitter, like a little key. It actually works to shut the receptors down or make them less reactive to starting the little shocks, but we don't have to get into that. But it is a neurotransmitter, okay? So this can make it worse. This is a little drug that it's actually a natural substance, if it's the same one that builds up in your muscles when you've been running. All right, those are respiratory disturbances. So anything breathing, but you can think about why that is. So that's what they think might be biological reasons. Now, what about cognitive reasons? All right. So one of the big things is that the cognitive model, and this is a psychological view, right? A cognitive model, one of the theories is, and treatment approaches is, that people who have panic attacks or panic disorder, which panic attacks is the key part, is they tend to make catastrophic misinterpretations of physiological sensations, right? So be like, oh, is my heart rate increasing? I wonder if I'm getting scary. Oh, this is going to be horrible. Must be a panic attack coming. All right, so it's a catastrophe when they read their bodies too much, right? Like my mother does not like feeling her pulse. That freaks her out. Now, I don't think she has panic disorder, but it's the kind of thing where people are like starting to think in a catastrophic fashion. Oh, this is going to be terrible. And you have a style of thinking. We're going to get into this later on with other disorders too, especially with depression, that you look for these thought patterns. That's what cognitive means, right? So if you're thinking, oh, this is going to be terrible, you actually kind of work yourself up into a panic attack, which then the next time is even more likely you're going to think that, all right? So a little more behavioral, so almost Pavlovian, is that you've got little cues inside of you and maybe some external cues that when you have a panic attack, it's actually like a, food bell thing. And then when you run into those cues or you experience those internal cues, right? Your breathing gets a little bit hard, fast. From a conditioning point of view, that means a panic attack is going to come. And then especially with an associated history of uncontrollable or unpredictable negative events. So anxiety itself is like the bell that says, oh, there's a panic attack coming. It's like your body's getting ready for it. Like in Pavlov, the reason why there is conditioning from an evolutionary point of view is your body wants to get ready for what's coming. So it starts to associate what's coming. The only way it knows what's coming is what is around the last time it came. Right? So if the guy in the white coat brings the food, the dog's brain's like, let's associate food with the white coats and let's salivate because we want to get, our mouths ready for the meal. So same way with anxiety. It's almost like you're getting ready to experience something scary. A lot to talk about here. So I'm not going to focus on the Freud stuff at all, but clearly, if there's one thing you should remember from the Freud model is that you got a lot of anxiety because you got all these impulses are floating around trying to get out, right? You're not aware of it, and that's where anxiety comes from. So SSRIs, we went over this with a little commercial. Serotonin selective reuptake inhibitors, right? So this is a treatment that may work at the synapse level. So behavioral and cognitive behavioral therapies typically involve exposure to feared stimuli. And we're going to talk about that. I think at the end I'm going to talk a little bit about treatment. So that's one disorder is panic disorder, of which panic attacks are a part of. Panic attacks can be a part of or not a part of agoraphobia also. So agoraphobia is anxiety, intense anxiety about being in places and situations in which you can't escape. So a lot of people don't leave their homes because they're so fearful of going out, and it seems to be a theme of not being able to escape or be in control, or they're terrified of being embarrassed in public. Okay, people can have panic attacks, and that's the reason why they stay in the house, but it's usually because the panic seems to be a little more tied to something. All right, in the old days, panic attacks had to be out of the blue, had to be out of nowhere, no clear trigger that you could associate. With agoraphobia, it's much clearer. You don't want to be in a closed-in situation outside of your home. You don't want to be outside of your home in any sort of area or place where you might not be able to get back home. All right, so it's a little bit clearer with agoraphobia than with panic disorder. Agoraphobia can also occur without a history of panic attacks. Yeah. So they don't include this in the slides. This should be in the book. And I forgot, I checked last time I taught this course. But this is right from the DSM-5. So you have to have, this is how the things work now. 4 chapters, half of all this stuff, and finally we're at what does it look like? Right? If you were going to diagnose somebody, what would you have in front of you? What page would you be open to in the DSM-5? And if you were going to try to diagnose them with agoraphobia, this is the page that would be in front of you. So basically, people have to meet criterion A, B, C, D, and these. Okay? A, you have to have 2 or more of the following 5. Can't have 1. You have to have 2. Can have more than that. So one of the first issues here is 2 people with agoraphobia, they both have to have at least 2 symptoms, but they don't have to have the same 2 symptoms. I want you to think about that. Mark fear or anxiety about 2 of the following situations. Public transportation, so you cannot get in a bus, train. What's the elevator one? Elevator. It might be a phobia more, but it's usually more about escape. Phobia is just a trigger. We'll get to that. Being in open places, so some people don't like being on bridges, marketplaces, it's too open. Being in closed places, but this is different than claustrophobia. So what you're running into now is another issue that is going to be through the whole course, is when is it this and when is it that? Because they both have similar symptoms. Okay? Being in a line, being in a crowd. So I knew I treated somebody who could not be in a store with people behind her or in front of her. I think it was more behind her. All right. And being outside of the home alone. This is the big one, really. I don't know in terms of frequencies, but when you think of agoraphobia, this is the main one. But all these can be related. Okay. And you have to meet criterion B. So you got to meet criterion A, which is 2 or more. Got to meet B, which you're terrified that you might not be able to escape, or that you might be incapacitated, or somehow something horribly embarrassing would happen to you. And the fear of that is so strong, you just want to get out of there. Okay? And you avoid the situations. The situations almost always, you can't like half the time not have a problem with it. So you have to actually, and people, you have to meet criterion C, criterion D. You have to actually avoid situations. And, or if you don't, you have intense fear and anxiety if you somehow manage to just endure it. In the old definition of phobia, there was 2 criteria. One of them was you had to actually not be able to be in that situation, right? So you could not really get on a plane if you have flight phobia, flying phobia. They've softened it so that you can actually be in the situation and still get the diagnosis, but you have to be intensely full of fear and anxiety. It has to be out of proportion to the actual danger, right? So if you're in combat, you're not going to get a diagnosis. This maybe applies more to phobia. Let's make it more relevant to this. Like, if you're afraid to leave your house and you live in an extremely high crime-related area, and there's some chance that something bad's going to happen to you, like a good chance, that wouldn't meet criteria. It's got to be completely out of proportion to any real danger. I don't know what they mean by sociocultural context. I can think of, anyway, maybe for another time. Now, F is a big one. It's got to last for 6 months. It says typically last. It's got to be persistent. So here's a little thing Rosenhan would freak out about, right? Persistent. How do you define persistent? This is where inter-rater reliabilities start to drop when you use these kinds of terms. Lasting for 6 months or more? What if it's 5.5 months? All right. Significant distress or impairment. Again, a Rosenhan issue. What's significant? Where's the number for that? All right. If another medical condition, you can have conditions that basically make it uncomfortable to be outside, where you're like looking for a bathroom, or you might fall, or something horrible. It's got to be that it's really out of proportion even to that. Okay, so that's your first exposure. And so if you get that diagnosis, the MD, does not necessarily write this. He writes this. He writes this number. Okay, he writes 322.22. That is what you would have on your form that goes to the insurance company. They make it nice and easy for insurance companies. Okay. Okay. And there's one last one, not explained by symptoms of another mental disorder. You could have like paranoia, where you might also be like that, but it's more paranoia, is all they mean there. And there's other reasons. I'll have you read those and we can discuss them. And I don't believe in this bottom thing. That makes no sense to me. That makes no sense to me. So, and then some information about it, 12-month prevalence rates for agoraphobia. Not so much older. Think about why that might be true. Genetic link to phobias. Is that a family link to phobias or a genetic link to phobias? We won't get into that, okay? Exposure-based, virtual reality. So the latest thing is you can put, the VR thing on people's heads and then have them approach different situations they're terrified of. And, you might do some relaxation. You might do pure exposure therapy, which I will talk about a little bit here. Okay, so you notice some of these treatments are the same. All right, specific phobia now is another disorder, right? So specific phobia, there's going to be a separate number for specific phobia. Intense and persistent fear triggered by specific objects or situations. So you see now it gets a little tricky. Well, agoraphobia is involved situations also, but I try to clarify some of what makes it different. The fear is excessive. So if you have a fear of flying, in reality, you get a phobia if it bothered you enough, which we'll talk about the symptoms. They're going to be similar to the agoraphobia ones, because flying is one of the safest things you can do. It's safer than going down your stairs. If you're afraid of spiders, the odds of you getting killed by a spider, you have more of a chance of getting struck by lightning while you're drowning than being killed by a spider, right? I mean, you gotta be a little careful, but most individuals, as their reactions are excessive, unreasonable. It doesn't matter, right? It's got to last at least 6 months. Interfere significantly with a person's life, or associated with marked, which means a lot of distress. Okay, these are different types. I don't understand this, but apparently people have it. Anyway, so that's all on there. Where's the needle phobia? I've had students like this. I know people like this. I'm not sure they have a phobia, but they faint. Like if someone brings out like the needle to take blood, they faint. And some people have a fear of it. I know a lot of people, adults, who like terrible, terrible fear reactions to thunder and lightning. Pookie has a fear reaction to strangers coming in the house. It depends though. So that's why this blood injection injury type thing, like blood, freaks people out. But like I said, I don't know if the fainting thing, which I had some students, when they had to get tests for things, they were going to work with me, and they had to get like medically clear. They were like, I'm going to faint. I'm going to faint. And then other types, clowns, not helped by that. What is that movie, It? Anyway, but people have fear of clowns. And I know people who have fear. I'm like, what? Not very understanding, I know. Okay. They apparently forgot to address its reliability in the DSM-5 field trials, which is when they get information to get those kappa numbers that we talked about. Pretty common, again, women more so than men. All right, so all right, identical twins versus fraternal twins, higher, not conclusive. All right. It's an interesting point. Like, why don't we have phobias to plugging in things into the? I mean, we've been shocked. I've been shocked a number of times. I don't have um, phobias to it. I mean, that's pretty classic. It seems like through evolution, our brains are wired to be more ready to develop fears to some things than others, like animals, the dark, heights. There's a ton of research about monkeys and fear of snakes, and was it inborn? Like, could you actually have a fear of a specific thing that's inborn? Which I don't think so. So behavioral causal factors, Pavlovian model should be obvious. If not, look at it again. Operant conditioning is if you're afraid of something and you do something to avoid it, you've just reinforced your avoidance response, because negative reinforcement is when you take away something unpleasant. Your behavior ends up taking away something unpleasant. We just reinforced whatever you did. So people take drugs. If it makes unpleasant emotions go away, you just reinforce drug taking. If running back into your house reduces your fear of having a panic attack, you just reinforced, staying in your house. And observational learning, which I do believe this for fears, that you pick up, you watch your parents very carefully. When you're extremely young, and you can pick up stuff about what to be afraid of and what not. So some Freudian factors. All these Freudian explanations are going to be kind of general for every disorder in the rest of the book. Okay. So treatment, we'll talk about that at the end. Social anxiety disorder is similar to specific phobia, except that the symptoms are connected to situations of the person exposed to unfamiliar people or to judgment, the scrutiny or judgment of others, right? And you're afraid you're going to do something that's embarrassing or humiliating. Again, if you're confused as to how this is different than agoraphobia, that means you're paying attention. And that's a big headache if you get somebody who's afraid of being around people because they're terrified that something embarrassing is about to happen. Right? That should be confusing to you if you're following this. If you're not confused, you're not following this. Usually it's a much more concrete situation for social anxiety involving a lot of people around, and you're afraid that when you're in front of all those people, something bad's going to happen. All right? Especially around their judgment of you. Agoraphobia, it's a little more general about being out in public, and there might be some people around. It's a little bit more of a general thing. This is more specific to groups of people, is one way that I would explain it. All right. Could escalate into panic attacks to make this even more confusing. Yes? Could be shyness, which is not social anxiety, and shyness related, but not really the same thing. Comfortable, nervous around people, to be anxious. All right, it's got to interfere with your normal life. I've got a lot of students where it's sort of borderline interferes because they can't make presentations or they can't speak up in class, which if it's a small class, then it would cross the line into interfering. I mean, larger class, you can get away with it, but you can't in a small class, especially if it's part of your grade. So you can see how the definition of that depends on where it depends. Subtype is performance only if the fear is limited to performing or speaking in public. There's some athletes. Who's that famous hockey goalie? He used to throw up before every game. He's so nervous. Um, I mean, every game, like for years. All right. So one of the most common anxiety disorders, onset, more common among women, right? Yeah. Causal factors. Now, it runs in families. Does that mean it's biological? Some interesting research about um, people's brain responses, different for people with versus without social anxiety disorder. They have different reactions to new faces versus familiar faces, are stronger. In the amygdala, if you jab something down into the amygdala to measure it, or maybe you can do it like Jesse Sargent does it, but with the EEG thing. Can't really measure brain areas with the EEG, but there's other ways you can do it. Learning models, you pick it up from people. Did bad things happen to you when you were younger? It's not really clear, which is why it's a little different from PTSD. People pick up these social anxiety. I mean, internal conflicts that produce yeah, see, it's the same thing. The book even admits we don't have really a different explanation. It's just something in your childhood that happened. You got this anxiety, and it's going to come out around people. You know, so it's tricky. It's tricky because um, there was a number I had read. It was just, I don't know if it was 40% or lower, that people could actually remember something that happened that they could relate to the phobia. But that's a minority of the time. It wasn't like a larger than 50 number. Um, but that's what a learning model was. So you learned it somewhere. But it might be that people pick up on stuff too more when you're younger, especially if you have a mother or father who's really anxious. Growing up in scary environments when you're young. So they have tried things for social anxiety, but you gotta be careful when you're using anxiety meds. Things tend to bounce back. Um, but you can get medications that tend to be anti-anxiety. Now, some of the antidepressant medications seem to have an anti-anxiety effect also. So you can be prescribed an antidepressant. Yeah, benzodiazepines, that's just like, you know, just knocking anxiety out. That you get a bounce from that. When you go off the medication, your symptoms come back like that. Right? Whatever you're socially anxious about. So this is almost like a personality disorder. You'll understand that more when we get to personality disorders, which is actually the next thing we're going to cover, which is chapter 8, not chapter 7. So after chapter 6, we're going to cover chapter 8. This is like generally being in a constant state of worry and apprehension about lots of things. You tend to worry all the time, or most of the time, about a lot of different things. Right? The old term was kind of neurotic. And to be worried and nervous about stuff. You know, that you don't sleep well. There's physical symptoms, autonomic arousal, which, sympathetic nervous system being kicked in a little bit too often. You don't sleep well, your muscle tension, you're kind of irritable, you're tired a lot. Now, you can imagine there's lots of physical disorders you need to rule out before you actually diagnose generalized anxiety disorder, right? Because one of the criteria is going to be cannot be due to a medical condition. People with GAD find their worries difficult to control. They can't talk themselves out of their worries. They don't like being worried all the time. They cause them physical problems. They do not progress into panic attacks. It's a generalized anxiety disorder. Fairly common. Reliability is horrendous. That's terrible, right? It only goes 0 to 1, so it's mostly like you're hoping to get a 0.6, 0.7. 0.2 just means like the inter-rater reliability is horrendous. So, yeah, brain pathways, maybe somebody did a research study, found a little bit of different reactivity in this brain area with people with GAD, without GAD. Again, GABA is one of the keys. It's a neurotransmitter like we talked about, but it's a key that when it goes in the lock, it it uh, it actually prevents the lock from doing a little electric charge when it turns. All right, it's an inhibitor. It's an inhibiting neurotransmitter, which we didn't talk about at the time. All right. Modest heritability. So they look for, again, none of this is sure. They do some studies. I don't know the research behind a lot of this stuff, but I mean, there's nothing that clear. At least when I was in training, maybe something new has come up. But generally, they try to find that people who live in, kind of very uncontrollable, unpredictable situation with negative things are happening. You're not going to, maybe not getting beaten, but just uncomfortable, scary things. And you can't really distinguish when things are safe and when they're not. And they're saying one of the theories that whatever is associated internally with anxiety is almost like becomes associated with the physical symptoms related to anxiety actually then predict anxiety and trigger it, like the bell triggers salivation. Cognitive overappraise. They should explain that. That's terrible, but I don't even know if the book explains that more. Tend to threatening. All right, so you tend to look more at threatening cues as opposed to non-threatening cues. So you look in a room, you might be looking at the ceiling. That doesn't look very safe, as most people aren't going to notice that kind of stuff. Unconscious conflict, which overwhelms the ego defenses, the same old stuff. Okay. Not much treatment we know about it. I mean, if you can get, you would do cognitive treatment for this, right? You got to get at people's underlying tendency to think in catastrophic ways. Oh, my nose is running. I must have COVID. All right. You'd look for those tendencies, and if you can get at general thinking tendencies, it would be helpful. All right. I'm not sure how much the research support that. Okay. So mixed results with the research. So this is usually in kids. So you'll see this with when they're taking the kid to school and the kid freaks out completely. All right. May proceed. I don't know what may proceed means. Strong predictor of subsequent mental disorders, particularly panic disorder and major depressive disorder. So a little breakdown in the relationship between mother and child. Probably a breakdown in that real primary connection, attachment. If you had developmental psych, you want to think about attachment stuff here. All right, and selective mutism. Don't ask me why it's here. Persistent failure to speak in situations where speaking is expected. Right. So, what's that movie? Don't Say a Word. Mercury Rising. There's a movie where the kid can't speak, but he knows some big secret. Like these bad guys are out to get him, like some code to get into a bank vault or something. And, right. So, failure to speak in situations where speaking is expected, school, social, but it does speak in other situations, like you're home and say, "Do you want some ketchup?" They'll say, "Yep." You got to rule out physical disorders. I'll let you read about that. Antidepressants, why throwing that stuff at people? Anyway, I mean, it's used. Some people need it. Don't get me wrong. And there's some other things, medication-induced anxiety disorder. This is all a little bit more medical stuff due to a medical condition. So don't worry about these things, but just know there are other things other than the more psychological disorders All right. So there's OCD and related disorders. Okay. So in this category, it's not just OCD. There's body dysmorphic, hoarding disorder, the hair pulling, skin picking, and some others. Okay. Now OCD is tricky. So you have to make a distinction between obsessions and compulsions, and of course there's a little gray area. But obsessions are thoughts that intrude repeatedly into your awareness and you don't want them. All right? Sort of like worrying, but people who worry, they feel like they should be worrying. People who have obsessions have these terrible thoughts. Um, Sometimes it's about stuff they're afraid they're going to do that they're not going to do. They have no urge for it, but they're afraid of doing it. Like they're afraid they're going to punch people when they're walking down the street. Um, and that they have these thoughts that this is going to happen. Okay? They're irrational. They don't make any sense. They don't want them, and they're difficult to stop. But it's not like urges or worry. Okay? Because most people worry. They're like, well, I wish I could stop worrying, but maybe I should worry about this. And compulsions are actions that you're compelled to perform. All right? Also experienced as irrational and difficult to control. Okay. And I'll let you read this. So key symptoms are obsessions or compulsions. Okay. They've got to be handicapping. They've really got to affect you. The greatest example is in the movie As Good as It Gets. Okay. So obsessions. This is the trickier one. These are thoughts, usually. These are thoughts. Compulsions are actions, usually. Obsessions are thoughts. So you have thoughts about, oh, I'm going to get contaminated. Or you have doubts about something. Maybe I'll never amount to anything. It's, you know, but it's not really worrying. Forbidden urges. So something they're afraid they're going to do something horrible. I'm hitting my kid. They became like, they have these thoughts that, oh, I'm going to hit my kid. I mean, they don't really have urge. It's not an urge. And you would distinguish that. It's like there's just these thoughts that they might do it, that they're not going to do it. They have no urge to do it. It's an anxiety thing, but it comes out in the form of these repeated thoughts. I'm going to get disease, all right? Being afraid of getting a disease. And it'd be more like thoughts, not a phobia. Again, I can't I can't give you the exact magic phrase that will make it easy to distinguish, but you got to have a sense of this is sort of more obsessions or things that keep coming at you as specific thoughts as opposed to you're afraid of getting germs, right? I might get a germ here. It's more clear, but a lot of times about forbidden urges, right? Or people who drive over a bridge, they might have obsessions about I'm going to drive off the bridge, I'm going to drive off the bridge, and they're afraid to drive over bridges because they keep telling themselves they might drive over the bridge for some reason. They can't really identify it clearly, and it's more of a thought. It's not an urge. So those are obsessions. And compulsions are more that you have to perform an act, right? It's the same thing like you don't want to step on a crack on the sidewalk. Almost like superstitious stuff. People do counting compulsions, and this is kind of like a thought. When you go in a room, you have to count all the tiles or count all the cinder blocks in our beautiful cinder block walls in Media Center building. So counting things are compulsions. Hand washing compulsions. You got to watch that movie. Maybe we'll show us a scene of that when we do our discussion. Okay. Checking, right? So compulsions. All right, let's do obsessions first. So recurrent persistent thoughts, urges, or images that are experienced as unwanted. So it's not like you want to drive off the bridge. You just have this terrible feel like you might drive off the bridge. You might have an urge to drive off it, but you don't really want to drive off it. Okay. Intrusive and unwanted, and they cause you a lot of distress. You might try to do something to make those thoughts go away, like tapping your head or something. If it makes the thoughts go away, it would actually start doing a compulsion to make the obsession go away. All right, compulsions are easier. Repetitive behaviors like hand washing, ordering, things have to be alphabetically. Like, are all your DVD? Well, do you even have DVDs anymore? If you had DVDs, like you would have to have them alphabetically. I had a friend I used to work with, not here. Man, his books had to be. I think he had them like in order of height in his bookshelf. So of course we'd mess with it. And he'd notice it. He'd freak out. He'd be very upset. That's not a nice thing to do. Checking. I know some of you are checkers, and I'm going to ask. You don't have to say anything personal, but I have a couple checking things. So I have this thing about making sure my lights are off in my car, like at night, that I have to go back. And the big one for me is that the doors are locked when I leave the house. So the cats know that when I leave, it's not for good. That I'm coming back once, sometimes twice, to make sure that the locks are done. I've been actually better about that for some reason the last year or so. But I don't have the full-blown disorder, but I'm a little bit of a checker. It's usually around lights, my headlights, and the locks. Sometimes if I've shut the faucets off. Feels driven to perform in response to an obsession or according to rules that must be applied rigidly. All right? And so what, like the hand washing is to make the anxiety go away. All right? And it's usually preventing some dreaded event or situation. So people who hand wash, like in that movie, you got to watch it as good as it gets. At least watch the scene where he's washing his hands. That's usually about something like you're going to die from a terrible illness. And it's not like a psychotic thing. It's more like you just have a terrible fear of getting an illness. Okay. And same thing now, A, B, C, D. So let me just point this out. So to get OCD, you can have obsessions only, compulsions only, or both. All right, so obsessions, you'd have to have 1 and 2, and compulsions, you'd have to have 1 and 2. But if you have just 1 and 2 for this and not for here, you'd still get OCD, not just OD. I'll let you chew on that. Okay, not affected to C, not affected to a drug, not explained by symptoms of another mental disorder. Time consuming. I can't even watch this stuff like that. They'll be on Oprah or whatever, or people coming and talking about, like I've seen this one guy, it freaks me out. Like he had to clean the house every day, like constantly, with a toothbrush. That's how he wanted to get to the germ stuff, to the dirt. He wanted to make sure there was not a speck of dirt. He cleaned his house with a toothbrush. He couldn't work. I think he couldn't work, couldn't leave the house because he was doing that all day long. Just some prevalence data. Some biological studies, some brain differences. You know, they try to study kids who might get it from family patterns and see if their brains are different before they have it. You know? But again, this is the big thing. You don't know if you already have it. You don't know whether the differences in your brains from people who don't have the disorder is cause or effect. It's like riding a bicycle. Your brain's going to be a little bit different. OCD increased people have these. All right. So two-factor theory, which I won't go into right now. All right. And obsessive persons use several defense mechanisms to reduce anxiety. OCD is related to being fixated at the anal stage. Remember we talked about that? Okay. And you can get antidepressant medication. The SSRI seems to have helped with the OCD a little bit. Unresponsive cases, they take out a little part of your brain or they cut it. I don't know what other symptoms people get from having a small bundle of nerve fibers connecting that part of your cortex to your frontal lobes, I don't think it's a common operation. All right, and then exposure and response prevention, which we're going to talk about. So body dysmorphic disorder, I'll let you read that. You have to be really preoccupied with a defect. A lot of people, right? Everybody worries about something about their bodies. You know, something about your nose or your eyes, or it has to be either imaginary or so slight that it's clearly like odd. Now, where that line is, we get back to all that stuff in the first 4 chapters. Who decides what the line is? How do you decide what the line is? Is the person across town who's also given diagnoses, what's their line for clearly excessive? And keep in mind, all this stuff is you have it or you don't. There's no like I'm 8 on the body dysmorphia scale. No, you gotta have it or you don't. So usually wrinkles, complexion, you see some of these movie stars who have all that Botox jammed into them and the lip stuff and I mean, there's got to be something going on with some of them. I'm not saying it's that common that they would actually meet criteria. All this stuff, though, I mean, where's the line? And is it a line? Or is it really just increasing gray area? All right, I'll let you read that. CBT. So some of the treatments, right? I am gonna go over a little bit towards the end. Compulsive hoarders collect items that they are later unable to discard. They have persistent difficulty in parting with personal possessions, regardless of their actual value. And most hoarders I've seen, I can't watch those hoarders shows. Oh my gosh. I mean, it's trash. It's like literally trash. They cannot get rid of anything. There's a hoarder in my neighborhood who has moved out of their house they have filled and is in another house and have filled that, and their car is filled. The way you really tell, I mean, separate from the criteria, is when the cars are jammed with stuff. And you might notice that. Clinically significant distress or impairment, I don't know. These people, they're okay with it. Compromises living areas, yeah. Runs in families. Does that mean it's biological? Okay. I'm not saying that's not possible. It's some brain areas overdeveloped, underdeveloped, overactive, underactive from some slight variation in your neurons, but they just haven't identified it clearly and consistently. So, and whether it's those kind of variations in functioning anyway are cause or effect. It's a little thing when people pull out little hair and they have little bald patches. I'll let you read that. Pretty straightforward. Habit reversal therapy. You've got to pay attention to what you're doing. You treat it almost like alcoholism, like what are high risk events? It's probably involving stress and coping with stress, so that has less of an effect. Stimulus control techniques. I think one thing they train people, move your hand up there and then away without pulling. And you have them practice that. So there's other things too. There's a skin picking version of that, which I really don't feel like going into. But I want you to read it. And then the medical related ones. So I'm going to give you just a little bit of a taste of something just fell over there, of treatment. Okay, so So let me do this. I think I'm going to do that yet. Hang in there with me. Not sure why that's showing. All right, pause this. All right, so one of the behavioral treatments is systematic desensitization. Now, there's another one that is called exposure, which is based on Pavlov. This is not so much, this is related to Pavlov, but it's not pure extinction. So what you have to remember from your Pavlov is if you're going to get rid of a dog salivating to a bell, what do? You give the bell without the food. Now, it's a little different for systematic desensitization, but I'm going to go over this one first. Very common. You're never going to see it in a movie because it's really boring, and a lot of therapy can be very painstaking. It doesn't make for good cinema. Do you know what I mean? So a lot of stuff I'm going to talk about, you're like, well, I've never seen that in a movie. Yeah, because it's not going to bring the crowds in. So this is an example of one of them where it kind of takes a while to do, but it's extremely effective. It's kind of based on Pavlov, that you're going to condition relaxation to the feared stimulus, and so the stimulus evokes relaxation instead of fear, because you can't be relaxed and afraid at the same time. All right. So this is systematic desensitization. Okay. It's called counter conditioning, and what you do is there's 3 stages. Well, we use their definition of 3 stages. The first is, and this takes a while to do, you teach people how to do deep muscle relaxation. It's called muscle relaxation training and breathing exercises. And eventually they get very good at being able to relax themselves completely just by saying to themselves, relax. Because they've done all this training, which I can go over in the discussion with you. Okay, I'll send you the links to this stuff. All right. Now this one, we're going to focus on spider phobia. All right, you can do social anxiety or social phobia treatment for this also. So, but you've got to do that first, and the first part of your treatment is that. Now, once your client has learned how to relax, then you build a hierarchy with them about things related to the feared stimulus. So with spiders, you have them break up or make a list. It's broken up into, say, 10 items, where at the bottom of the list is a version of the stimulus that is not very scary. So the fear rating, 0 to 100, usually called the SUDS rating, subjective units of distress. So if somebody's got spider phobia, you might think about a spider. All right. Someone who's got public speaking phobia, you might say, okay, think about you have a meeting in a week. All right. Or you're in the classroom where you have to speak 2 weeks before. But you build up what's called a hierarchy of different situations, and up to the most feared one, which is what you're in counseling for. And what you do is you basically train the person to be fully relaxed at each of the lower situations, and when they're successful at that, you then go to the next one. So this one, think about a spider, look at a photo of a spider, look at a real spider in a closed box. I mean, that's a 50. That's pretty quick for this. I wouldn't have that till the 50s till up here, I guess. All right, hold the box with the spider, let the spider crawl on your desk. I would break this up even more. So the patient works their way up the fear hierarchy, starting at the least unpleasant and practicing the relaxations. So what you do is you get them fully relaxed, and you say, okay, think about a spider. The person thinks about a spider. If they can get through like so many seconds, then you do it again. If they're able to do it again without getting anxious, then you go on to the next item in the hierarchy. Now, if you do that right away for the first 3 or 4, it means you've done it wrong, that they're too easy. But But what you do is the person, if they feel anxiety come up while they're thinking about the item in the hierarchy, they raise their finger. And the therapist goes back, has them relax, and goes back to the previous item in the hierarchy, not the one they were working on. So you have to be fully relaxed at the earlier levels so that there's no anxiety. So when this is done, you go all the way up. I mean, you wouldn't go all the way up when you're at the latter end of the therapy, but you would have gone all the way up with no anxiety for at least for each stage at some point before you could move on to the next one. It works. It's very powerful for all kinds of phobias. So, now the hardcore way to do treatment is well, let me do this one. So I'm going to show you this video. I think you should be able to hear it. I tested it out. All right. So this is a conference, okay? This is a conference, and sometimes at conferences like that I go to, they will have people with a problem at the front of the room, and then a master therapist will like treat them for the problem. I mean, it's not meant to cure anybody. It's not like a hypnosis, magic trick, Penn and Teller thing. But they'll go through like some things they would do that's helpful, and then explain how that would fit in a longer therapy. So this guy specializes in one treatment exposure therapy. Okay, he's like fully certified, respected, PhD, clinical, scientific type psychologist. But he does short and even one session phobia treatments. And this is an example of what he would do. So he's got a woman who is not, it's a woman with a dog phobia. All right, watch what he does with her. You should be able to hear this. He brought his dog. He's from Sweden. I don't know if he's based in Sweden.
Do you see him?
90.
Okay.
So he's already told her, give me a rating. This is exposure therapy. This is pure Pavlovian, bell, shock, fear, and now you're going to give the bell without the shock. There's no relaxation stuff in here, right? This is pure Pavlovian extinction. And if you don't remember it, you need to go back. It's pure Pavlovian extinction of conditioned responses. And I've done trauma therapies like this, where you walk people through the event. There's none of this systematic hierarchies, have them relax. You just go for the whole event. You got to go slowly because lots of reasons, and I can talk about this more if you're interested, how I've done it with PTSD, with people who've been traumatized. You basically walk them through the event again. This guy does things like phobias, so I did it more with post-traumatic stress disorder for events. This guy does objects, and he's going to treat this woman for dog phobia. So he's already instructed the woman, tell me your, what stress level from 0 to 100, and he's asking her, and he walks in with the dog, his dog, and he says, what's your number? She says 90.
Do you want me to stop here?
Mm-hmm.
Sit, Max. Sit. Sit. Good. So what is it now when you look at him that is frightening?
Well, he's got a very large muzzle and hopefully lots of teeth.
So this might relate back to the cognitive model where she's focusing on threat cues. Like she's just looking at, she says, what do you notice about the dog? What does she notice? The mouth and the teeth. So he's sitting the dog down. He's letting her sit with the anxiety to extinguish it, right? You just need to keep ringing the bell till the dog stops salivating. And he's letting her sit with it. But he's doing something else here, and I'm not sure how much of a part is his therapy. And there's an article I could have you guys read if you're interested. But where he's giving her a little bit of a sense of control over it. He's not going to just walk the dog right up to the stage, and that might be part of it. It's not purely an extinction thing.
And he looks very, very strong, powerful.
But it's a very well-behaved dog, as you can see. He's just sitting here.
Still, I wouldn't want to touch him.
Okay. Could I get a bit closer?
Maybe a little bit.
Okay. Come on, Max.
She's got dog phobia.
What about here? Sit. Max, sit.
He doesn't always do what you say.
No. That's probably because I'm a lousy dog keeper.
Her appraisal of her environment
Not because
is all around
he isn't
threat
a
cues.
good, well-behaved dog. Sit. Good. What's your anxiety level now?
95.
Gone up.
Okay.
Watch this though.
He doesn't bark a lot, I'll give him that. It's definitely worse when dogs bark. And he's not looking at you, which is good. He seems to be more interested in someone back there.
Yeah. Can become closer.
Maybe a little bit, yeah.
What about here? Sit, Max. Sit. It's probably more difficult for him with all these people around.
He looks a little bit scared, actually.
There's someone he knows.
My anxiety's coming down to about 75, 80.
Good. Good. Could we get up on the podium?
Maybe just come right to the edge.
Down. Good. Right. Sit here.
It helps that he's not looking at me and that he's kind of whimpering rather than barking. You've got tight hold of the leash?
Yes. What's your anxiety level now?
About 50. My heart is not pounding anymore.
Good. It was 90 when we entered, wasn't it?
Mm-hmm. But I feel like I kind of know. I don't think he's going to bite me. I can honestly say that.
Good. So what makes you say that?
Well, I think if he was going to bite me, he would have run up, or at least would have been barking or looking at me. And he seems like he is more interested in looking back there.
Yeah, that's probably true. So just by approaching and showing you that he is a well-behaved dog, your belief in being bitten has gone down.
Mm-hmm. But what if he wasn't so well behaved? What if there are lots of German Shepherds out there who attack people and children
And that of course is a possibility, but what we want you to be able to do after this treatment is to be able to walk around in the streets and go jogging or whatever you want to, without fearing that you will be attacked by a dog, because even if it is a possibility, it very rarely happens. I mean, it's a possibility that you get run over by a car when you're out walking. And that very rarely happens, but it's still a possibility. Living is dangerous. You can die from it. So that's what you have to
She doesn't
accept.
think that's very funny.
Do you think you could try patting him with my help?
Okay, but not on the head.
No, on the back. Sit. Max, sit. Down then. Okay. So if you were to do it like that, you could start by putting your hand on my hand, and then we gradually do it like this.
Little Skinner stuff.
And if I withdraw my hand a little, you put your hand on. Good. What does it feel like?
Gradual, it does.
Kind of roughish.
Yeah. What about your anxiety?
It's still at it's 45, 50.
Good. Great. Could you try it further up here?
Okay, you're holding on to the leash?
Yes, I am. Good. Very good, Misha.
He doesn't seem to be too interested in me, which is good.
Why is that good?
Well, I would just think that if he wasn't liking the way I was touching him, or if he was looking at me, then he might be more likely to kind of jump up on me.
Yeah.
But no, he doesn't seem very, very affected at all.
Good. Very good. Do you think you could come up furder, pat him on the head? Good. Very good. He's just noticing you. He doesn't want to bite you at all. That's nice. Very good, Misha.
Relax.
What's your anxiety now?
About 20, actually.
20?
20 or 25.
Good. Very good. It's a bit sensitive on the ears. Very good. So what about your thought that he would jump up and bite you?
I definitely don't think he's going to bite me. I guess what I keep thinking right now is, okay, Max is a nice dog, but what about other dogs out there who aren't as well behaved?
Yeah, that of course is something we always have to realize, that there are other dogs that...
So I'll send you the link to the video. Remember this though, the link to the video, I cannot find the link to the video. There's a link to a page. I wasn't able to get a link off of this or anything. I tried it, and it was not like your grandfather trying to do this, but make sure you're going to get to this page and you click on this thing which says Lars Garan Oost, because the other one, you can watch it, but it's a very graphic, similar treatment of a rape victim, and if you don't want to go through that, don't go through that. So make sure you click on this one here, okay? But you'll see there's another 7 minutes to this video. You've got to watch it to the end. Max is a big goofball, but anyway. So now what you can do is you can go to your phone and you can look on Google Play or iTunes and you look up Phobia app. Okay, so there's one that's called Phobia Free. This is an old article, but I thought last semester or the semester before we actually looked it up, we were able to find it. And it helps you with, I think they actually do systematic desensitization. where you have to learn how to relax first. I mean, that's the true systematic desensitization. There is something called systematic exposure, which is a little bit like the guy did in the video with the one with the dog, except you do it over weeks. You know, I might bring the dog up here. You could do systematic exposure. Anyway, just systematically, just letting them sit with the fear and then go on. There's no relaxation component. That's pure. The relaxation component is, look at, psychiatrists are working to make that happen, not psychologists. Anyway, make sure you can see that. So what they do is, now if it's systematic desensitization, they have to have learned relaxation, and then you've got to be exposed to these images, lower end of the hierarchy, and breathing until, you have I think they make it like a game, basically, this fun game. It's called Phobia Free. There was another one. Was there another one? Anyway, so you can see at the lower end of the hierarchy, this little cute, funny spider, not very spider-like, with the little hat on. And so that would be some of the items, spider-related items at the lower end of the hierarchy. Now, as you successfully move up the hierarchy, you probably have to, you start to win points in the game by getting through without fear. Well, the spider gets a little bit more realistic looking. Okay. And then a little more realistic looking. And then the highest item in the hierarchy is this guy. So anyway, but you can look it up in the iTunes. I don't know if it's still up there, but they have another app, Stress Free, that helps users relax. Well, you have to relax if you can do systematic desensitization, but you can do exposure, which is just more extinction. You just expose the person to the thing you're afraid of, and you can do that in a systematic way also, but that would be called systematic exposure, no relaxation component. You just in fact, you want people to be afraid because that's the mechanism for extinction. Is afraid, but there's nothing bad happening. That's different. And I forget if this is truly systematic desensitization, in which it has to be a relaxation component. Anyway, I'm going to leave it there, and we'll talk about all these things, and hope you're having a great week.